A hearty good afternoon to everyone, and welcome to a session on recurrent pregnancy loss. And we are glad to have Dr. Anuranjita Pallavi among us today to help us explore this topic. Now, it's important for us to understand that recurrent pregnancy loss can be caused by a variety of factors. So the doctor will shed some light over these issues. We encourage our audience to ask our doctor any questions or doubts they have related to the topic. So, doctor, you have the stage.
Thank you so much. Hello, I'm Dr. Anuranjita Pallavi. I'm consultant at Apollo Fertility, Navi Mumbai. So today I'm going to deal with a very sensitive topic actually. My topic for today is recurrent pregnancy loss. Why sensitive? Because more than physical, it has an impact on the mother mentally because it gets very depressing to go through the same thing again and again. And recently, I've been seeing a lot of patients coming with the same complaints of recurrent pregnancy losses, and because of which I have selected to take this topic. So, coming to the recurrent pregnancy loss, coming to the proper definition. If we go through the proper definition, it means that any patient who has lost the child, lost your child three or more than three times comes into this category of recurrent pregnancy loss. Now, recurrent pregnancy loss can be divided into the first trimester, the second trimester, or the third trimester. So all the three trimesters, first, second, and third. Now, the causes in each trimester for a pregnancy loss is different. Most commonly, what we see in our usual day-to-day practices is that most of the patients go into the first 3 months of abortion. That is, the first trimester abortions are most commonly seen. So coming to I'll go step by step for the recurrent pregnancy loss. First will be the first trimester, then the second trimester, and then the third trimester. So what are the causes for the first trimester? Means what I mean is first 3 months of pregnancy. If they lose their child, that comes into the first trimester abortions. Now the causes of first trimester abortion, second and third are different. Sometimes overlapping can be there. Coming to the first trimester abortions, what are the common causes of first trimester abortions? If we go through the literature, we will find that the most important cause, like in 50% of cases, out of 100%, you can imagine in 50% of cases, the cause of recurrent pregnancy loss is genetic. Genetic is chromosomal, basically. Any chromosomal abnormality is responsible for, recurrent pregnancy loss. Though there might be simple chromosomal abnormality in the parent, but when it comes in the embryo, it gives rise to an abnormal embryo, which can lead to recurrent pregnancy loss. So the most common cause in 50% of cases accounts for 50% of cases is the genetic causes, where I mean to say is a recurrent pregnancy, a chromosomal abnormality. Second, in the rest 50%, what we see is the second one is APLA, what we call it antiphospholipid antibody syndrome, which is an autoimmune disease where your own body recognizes these embryos as foreign and try to kill them. That is known as an autoimmune disease where the body is recognizing as a embryo as a foreign body, and it leads to abortions. So this is the second cause, which in common terms we call them as APLA or antiphospholipid antibody syndrome. Even ANA, like other autoimmune diseases, not only APLA, even the other autoimmune diseases like ANA positivity can also lead to recurrent miscarriages. Then the third common cause is TORCH group of infections, where these are the series of genetic what the torch infections are basically the viral infections which can lead to these recurrent pregnancy losses. So this is the third most common cause of recurrent pregnancy loss in the first 3 months. So, and the fourth one is any uterine abnormality, like a fibroid is there which can lead to a recurrent pregnancy loss, or a polyp can lead to a recurrent pregnancy loss. These are the normal, maybe the uterine milieu is not appropriate, due to which this thing is taking place. So we have four causes here, out of which 50% is definitely the genetic or the chromosomal abnormality. The rest of them can be either uterine, either autoimmune factor, or a TORCH group of infections. So these are the basic causes of recurrent pregnancy loss in the first trimester. Apart from this, hormonal imbalances can also lead to first trimester abortions. The first one being the thyroid. The second one being if the thyroid levels are high or less, hypothyroid or hypothyroidism, either of them can lead to again pregnancy losses. Or if the patient is diabetic in the peri-conceptional period, that can also lead to recurrent pregnancy loss. But then these hormonal factors can be responsible for, like diabetes. Diabetes can lead to intrauterine deaths later on in pregnancy also. So these are the most common causes of, or these are most the common causes of first trimester abortions. So I've told you genetic, then autoimmune, then torch group of infections, or any local uterine factors which are responsible. And then the fifth one being the other hormonal imbalances can lead to all these things. So these are the five reasons because of which a person can go into recurrent pregnancy loss. So in the first trimester. Now, what happens in the second trimester? What are the other causes in the second trimester? The most common cause of pregnancy loss in the second trimester is something known as a cervical incompetence, where the cervix is not thick or strong enough to hold the pregnancy. So that is the second thing which has to be kept in mind, that they will typically come with pregnancy losses are such that they will be suddenly in the second trimester, or 18 weeks, 20 weeks, they come with sudden onset of labor, painless labor. They have the characteristic feature of cervical incompetence leading to second trimester abortion is they will have painless labor, where suddenly they will dilate and the baby is expelled out. So this is the reason, most common reason in the second trimester for the pregnancy losses. For the third trimester, definitely hormonal imbalances like thyroid, which I already mentioned, or the diabetes, or other causes where the patient is developing PIH, pregnancy-induced hypertension. But then these are definitely not recurrent ones. So generally, it goes in the as the pregnancy advances and it leads to the death of the baby. It can either be the most common causes remains hormonal like diabetes or something else. So these are the basic reasons why do we go ahead with why do we have recurrent pregnancy losses in either of the trimesters. So how do we evaluate a patient, or what are the treatments which we can offer to avoid these recurrent pregnancy losses so that they do not have a mental impact on the couple as a whole. So what happens in the first trimester? How do we evaluate when a couple walks in with the first trimester, with a history of first trimester abortion? Suppose a couple has come, and then they give a history of abortions which has taken place like 4 times or 5 times. Suppose the embryo did not develop, or the embryo developed but the heartbeat did not come, or the heartbeat came and went. So how do we evaluate these patients? So as I said, the most common cause is genetic. So definitely a karyotyping for the couple remains the utmost treatment and utmost investigation, sorry, not the treatment, utmost investigation, where we do the karyotyping of both the husband and the wife. That's a blood karyotyping which we do for the where they analyze the chromosome and find out where the problem is. Secondly, what we advise them is, apart from karyotyping, they can also go ahead with the karyotyping of the fetus which was aborted. But most of the time what happens is, what the patient says is, till the time they come to the hospital, till the time they start bleeding and come to the hospital, the product of conception has already passed on. But if we get a chance, if we missed abortion, where we try to induce the abortion or try to do a DNC, where we take out the where we curate it out. So in those cases, we should definitely send the karyotyping of the fetus to find out what was the genetic abnormality in the fetus itself, as a result of which the couple is facing this kind of an issue. So that is one thing which the test which we do from the to the couple, that is the blood karyotyping. Secondly is, if suppose the karyotyping is like normal, then what else can we do to find out this genetic cause of recurrent pregnancy loss? The second test is, nowadays what we have is the whole genome sequencing, where we screen the entire genome of the patient and the husband couple. The entire genome is sequenced and found out exactly where the problem is, so that we can find out a solution to it. So that is another test which we avoid, which we can advise. So these are the two tests which we do for detecting the genetic abnormality. And first is the karyotyping of the couple, or the whole genomic sequencing, or the karyotyping of the retained products of not the retained, the products of conception. Then, coming to the other investigations, we have certain APLA panel where we find out whether the patient is suffering from any autoimmune disease, or we can have this ANA testing for other autoimmune disease where we can find out whether the patient is having any autoimmune disease, and so that we can start with the treatment right from the beginning, so the pregnancy can be continued. So this is about the APLA. TORCH panel is again TORCH panel. TORCH group of infections have, there's an entire torch panel of infections where we get the test done. But one thing which I want to highlight here is it is the IgM of the torch group of infections. Like we have cytomegalovirus, we have rubella virus, we have herpes virus. These are the common causes. Toxoplasma. So these are the 4-5 common infections which can lead to recurrent pregnancy losses. And whenever we do the test, we should always look at the IgM, because I get a lot of patients, where IgG is positive and still they're anxious about the fact that they might have these torch group of infections. So one thing which has to be kept in mind is the significance of these tests. The significance of these tests is dependent on the IgM value of the viral markers, which we do, not the IgG. IgG indicates that the infection has taken long before, and now the patient has only the IgG or the antibodies have been developed towards the infection. So these are the investigations. First was the karyotyping, second was the APLA panel, and the third one was the TORCH panel. And then the fourth one, which I was talking about, was the uterine abnormality. So uterine abnormality, we can go ahead with something known as a 3D pelvic scan and a hysteroscopy. If there is a fibroid, then the fibroid removal should be done. Or if there is a polyp, then polyp removal should be done. And then other hormonal tests are usually done. Our diabetes, for sugars we test for thyroid, and we can test for prolactin. So these are the investigation which are carried out with a couple who enters the fertility clinic with the complaints of a bad obstetric history or a history of recurrent pregnancy loss. There can be immunogenic factors also, unnoticed immunogenic factors where the again it's the same thing, that they have been treated like it looks like a foreign body to the patient, and then the body only tries to reject the embryo. So these are the investigations which we do it for a recurrent pregnancy loss in the first trimester. I'm talking more about the first trimester because I've been seeing a lot of patients coming with the same problem. First trimester are the most common problems, recurrent pregnancy loss. So these are how we are going to investigate a patient with a recurrent pregnancy loss. Now, cervical incompetence. If a patient has cervical incompetence, then the treatment remains we put a cervical stitch. As a precautionary measure, we put a cervical stitch so that the pregnancy is held on and pregnancy can be carried on. So now, what are the treatment options which a patient has? Once the patient has gone ahead with all the investigations, the treatment depends upon the cause, definitely. So if the cause is genetic, then we advise them definitely to go ahead with something known as an IVF. Definitely an IVF is advised to them. But then we have to remember that in a patient of recurrent pregnancy loss, simply doing an IVF will not provide them with any benefit. Why? Because IVF, anyways, they are getting pregnant. So even if in IVF we are forming the embryos and implanting it, how is it different from what they are conceiving naturally? So providing them with an IVF is not the treatment. Providing them with an IVF with a genetic screening of the embryos becomes the treatment of choice. So nowadays we have, initially it was termed as PGS, pre-implantation genetic screening. Now it is what we call as PGTA. So in these patients, what we advise them is, if the cause is genetic, definitely if the cause is genetic, then the treatment remains, IVF along with PGTA, where the screening of the entire aneuploidies, the screening of all the chromosomes to determine the abnormality is found out. And then we transfer those. See, sometimes it's a permutation and combination. Suppose, for example, we get 10 embryos of a patient, we send them for biopsy. So now it is a pre-implantation genetic screening where we screen the embryos before transferring them inside the womb, so that these things can be reduced. Recurrent pregnancy loss chances can be reduced. So when we do an IVF, So along with that, we advise them with PGTA. So suppose, for example, we send them some 10 embryos for biopsy. So out of which there can be one embryo which can be normal, there can be 10 embryos which can be normal, there can be 5 embryos, or there can be none. So this is a possibility which the patient has to be explained, that these are the chances that one embryo can also be and one embryo can be normal, two embryo can be normal, and none can be normal. So the benefit here is, if we transfer a genetically healthy embryo, then the chances of them continuing the pregnancy is high. So this is the treatment which we should offer to our patients who are undergoing recurrent pregnancy losses. With genetic causes, definitely with genetic causes, because if it is APLA, then we start them on low molecular weight heparin and blood thinners so that the pregnancy can be carried out. And genetic causes, the treatment remains IVF with PGS. Other causes, we treat them accordingly. If it is a thyroid issue, we try to correct the thyroid. If it's a sugar issue, we should correct the sugar levels. If it is infections, then we should give the treatment accordingly and not recommend them not to get pregnant for another 6 months to 1 year. So these are the things which we can do for a recurrent pregnancy loss in the first trimester. In the second trimester, obviously, the most common cause I've told you is cervical incompetence. So we put a cervical stitch 1 to 2 weeks, 2 to 3 weeks prior to when the uh, abortion has taken place. So, and then hormonal, we correct it accordingly. So this is the treatment of choice, and these are the reasons. And depending upon the cause also, like uterus, if there is a fibroid, we go ahead with the fibroid removal. If there is a polyp, we go ahead with the polyp removal. So that depends upon the cause. But most common cause, which was for me to highlight here, is if it is a genetic cause, then we go ahead with IVF plus PGTA, which is one of the latest technologies which we should give them a chance to have their own healthy baby, so that they come out of this mental trauma. So this was in brief about the recurrent pregnancy loss, about the immunological factors, about what all are the reasons for recurrent pregnancy loss and how do we manage them. Even when we do an IVF for genetic causes, we still give them treatment to, for APLA. Like, we always start them on low molecular heparin, irrespective of whether the APLA is positive or not. So we are dealing with each aspect separately, irrespective of whether they are positive or not, giving the patient a fair chance for the pregnancy to continue, dealing with all these causes. So this was in brief about recurrent pregnancy loss. You can get back to me if you have any queries. And it was nice talking to you all. Thank you so much.